Hello class, I'm just going to continue with what we were discussing in class the other day. I'm ready to start the discussion about drug therapy for our diabetics, and obviously since I will begin discussing the oral anti-diabetic medications, these are medications that we would give strictly to our patients with type 2 diabetes, patients that still have some pancreatic function, still secreting some bit of insulin, but still unfortunately making the person develop hyperglycemia. So these drugs are to hopefully bring down the blood glucose, and each one of these categories acts just in a little bit of a different way. And as I said the other day, for the newly diagnosed type 2 diabetic, if they aren't able to be controlled by diet, exercise, and maybe even the loss of weight, that's when the healthcare provider will consider begin them on some anti-diabetic medication. The first category here are your sulfonylurea. And obviously it's used when these patients do have some remaining pancreatic beta cell function left that actually stimulates insulin secretion from the pancreatic beta cells. So it kind of gives those beta cells an extra boost to kind of say, hey, we need a little bit more insulin on board to hopefully bring down that blood glucose. Okay, and these are just some examples of the medications that actually fall into this category, your glipizide, your glucotrol, and obviously with this category of medications, the big side effect that we worry about is hypoglycemia. The sulfonylureas have kind of evolved into a second generation of categories, and these are what this is what glipizide falls into. They definitely have a more potent effect than the first generation, and some of those medications would be like diabinase, tolinase, and orinase. Okay, and now they're in this second generation category, which obviously provides a little bit more potency of the medication, and obviously a better effect of controlling blood glucose. Okay. The next group of medication is the meglitinides agents. Those act by triggering insulin secretion from the pancreatic beta cells, and a perfect example of this is natiaglanide or Starlix. And how this works is it actually stimulates insulin secretion within 20 minutes of ingestion. So it's very important that when you're giving a drug such as natiaglanide or Starlix, that you give it within a period that a person is going to eat. Say for instance, you've got somebody maybe that is NPO, maybe because they're going to be going down for some diagnostic test and we want to withhold their breakfast. You definitely would not give this medication because they're not going to eat, because it actually does start working within 20 minutes after the medication is administered. So you wouldn't want to give it because it would obviously cause your patient to develop hypoglycemia. Okay. So that's just one really important aspect of this category of meds. It's very rapidly absorbed, taken just before meals. So again, the rules of this medication are if you skip a meal, then you skip the medication. Okay. The next group of medications are the biguanides, and they actually decrease liver glucose production. thereby reducing fasting plasma glucose release. And as I said the other day, a perfect example of this is metformin. And according to the American Diabetic Association, this is the drug metformin that physicians will use as the initial therapy for type 2 diabetes, because the good thing about this drug is it does not induce weight gain or hypoglycemia, and it can be purchased for a very low cost, and it really does have very, very few side effects. So that's why it's just a great choice to begin to see how patients react to some of these anti-diabetic medications, and metformin is a pretty safe one. It can decrease appetite, cause little GI problems in the beginning. Patients might have a little bit of nausea, even some diarrhea, but as the person gets a little more accustomed to the drug, those start to dissipate, and those kind of go away until the person gets used to that medication. But the good thing is it's not likely to produce hypoglycemia, okay? The next category of medications is the alpha glucosidase inhibitors, which actually inhibit or prevent after-meal hyperglycemia by delaying the absorption of carbohydrates from the small intestine. An example of those are Archibos or Precoce. The side effects that a patient may encounter with this group of medication is more GI problems like flatulence, diarrhea, and even abdominal pain. They really don't cause a lot of hypoglycemia unless they're given with some of your sulfonylureas or insulin. So may be the reason why your patient might develop hypoglycemia. Okay. The last category is your TZDs, and those actually help to improve insulin sensitivity and reduce liver glucose production. Okay. Avandia and Actos are perfect examples of your TZDs. They also can help decrease blood lipid levels. Some of the side effects with your TZDs are increases adipose tissue, sensitivity of glucose production and fluid retention, and can also increase insulin sensitivity and reduce liver glucose production. So those are things that we look for in regards to TZDs. And just as I said before, these categories of anti-diabetic medications all kind of act a little bit differently. And I think you have to look at the degree of hyperglycemia that your patient is experiencing. Obviously starting on one at a time to see how the patient responds to that. And we also look at other situations in a particular person, lifestyle. The drug selection may be based on cost, the patient's ability to manage multiple drug dosages, their age, and obviously how they respond to that particular drug. Especially for an older patient, they might want to order something that is more of a shorter acting drug than somebody that has, especially with the older adult that might have more of an irregular eating schedule. Also, they have to look at their health history. Are there any liver, cardiac, or kidney problems? Okay. Look at some of your medications that kind of are more longer acting, like your glyburide, where it might be taken, once every day. Maybe initially with a fair amount of insulin still being released, that might work for a while, but over time, if those beta cells start decreasing in functioning, secreting less insulin, it may lose somewhat of the effectiveness of the drug, and it might be time to look at what other drugs may be a little bit better for that person in controlling their hypoglycemia. Just another note that when we talk about the sulfonylureas, there's a couple charts in your book that actually talk about medications that your patient may also be on that affect blood sugar. A lot of types of drug interactions, especially if they take ACEs, maybe they have cardiac issues, may induce hypoglycemia more readily. Or there are some drugs like your calcium channel blockers that may worsen hyperglycemia. Things like Lasix, some of your corticosteroids like prednisone. So we also have to see how these drugs work in regards to what other types of medications that these patients are on, okay? Just another important fact about glucophage. We talked about this somewhat in the respiratory system, especially when your patients are going down for diagnostic studies. If they, by some chance, are having a diagnostic that has contrast media, remember we would probably withhold the metformin within 48 hours before and after the contrast media is given to prevent the patient from having an increased risk for lactic acidosis. And again, maybe metformin may not be the drug of choice as initial therapy, especially if your patients have some kind of kidney insufficiency. That's why it's important that we definitely assess and interpret their creatinine levels, okay? Because might be not the best drug to use to hopefully, control their blood sugar. Again, another drug here on the PowerPoint slide is Byetta or exenatide. It can be used with oral hypoglycemic medications for a type 2 diabetics. It's injected sub-Q. It is a fixed dose pre-filled pen, and again, works to slow the absorption of food in the GI tract to prevent those really high spikes in blood glucose. Remember, it's what we call a GLP-1 agonist, and it mimics the action of GLP-1 hormones by stimulating insulin secretion only when blood sugar is elevated, okay? And the big main side effect with this drug is nausea, and usually it's given about 60 minutes before morning and evening meals, and it should not be given, don't give after meals, okay? And when you have unopened pens, they're to be stored in the refrigerator and usually stored upright, and they're to be discarded after opening them up for after 30 days, okay? So that's kind of how we teach patients about these particular medications, especially when they're in the form of a fixed dose pre-filled pen. All right. Another category that I didn't have on the PowerPoint is your DPP-4 inhibitors, and an example of that would be like Januvia. That actually inhibits the enzyme that inactivates the incretin hormone, and they actually are drugs that inhibit the enzyme that breaks down incretin hormones. Usually with Januvia, about 100 milligrams every day is given, and it would be adjusted if the patient does have renal disease. Some of the side effects are stuffy, runny nose, increased risk for respiratory infections, and also skin breakouts. The big side effect with Januvia is to watch out for signs and symptoms of pancreatitis. So that's why if your patient would be on this kind of a medication and they start to develop abdominal pain or severe nauseated, it could be the beginning manifestations of acute pancreatitis, okay? And remember, we talked about amylin hormones that's secreted with insulin. We do have drugs that are amylin analogs, very similar to amylin for type 1 and type 2, works by delaying gastric emptying and reduces, after a meal, high blood glucose levels. And a lot of times, too, it also provides a feeling of fullness. So many times when your patients are on these, they will lose weight. You would not mix this drug with your insulin because the pHs are not compatible, okay? So those are some other categories of medications that I wanted to definitely go over with you, okay? And again, it's very important as we see our patients prescribe these certain anti-diabetic medications. Again, the physician will start that patient on the lowest dose. If they're not seeing the response that they want, getting those blood glucoses down, they will increase it about every 1 to 2 weeks, and maybe even add a second and possibly a third anti-diabetic medication. All three usually from a different category. And if we're still not seeing a sufficient, adequate drop in their blood glucose, then the patient will be started on insulin. And it's very important to explain to people that when they're on these medications, it's not a substitute for dietary modifications, meaning that they just can't go ahead and consume more calories. That's not what the reason for them taking this medication is. It doesn't give them a free pass to maybe eat extra calories in regards to desserts and even carbohydrates, okay? Along with some of this other drug therapy, as you can see from the PowerPoint, there can be combination agents, such as glucovance, combines with glyburide with metformin. And you may see the patient prescribed this type of medication because it has the effects of glyburide as well as the effects with metformin, okay? And again, review those important facts about how the physician will begin to prescribe drugs to hopefully keep that blood glucose within a pretty good range, okay? Now we go to insulin therapy, and many of you ask, okay, some of the sources show a little bit different ranges for some of these insulins in regards to onset, peak, and duration. Test questions will be based on the charts that are in your IGGI book. That's our book, and that's what we will use as our source of information in regards to what the ranges are for onset, peak, and duration of the different types of insulin, okay? Obviously with insulin, we have all different kinds that act very rapidly, acted within a very short amount of time. We have intermediate, and we also have long acting. Some of these can be given separately or some can be mixed, and it's important for nurses to really know what the onset, the peak, and the duration of these insulins are, because we know that through our drug books that a patient is most likely to develop hypoglycemia when that particular insulin reaches its peak, okay? And really when our patients begin the treatment of insulin, we really have to watch these patients very carefully, because there's a lot of factors that are involved that really determines, you know, when or how these insulins are absorbed. We know our rapid and short are insulins that we will see ordered for what we call our prandial type coverages. Our patients may be ordered on a sliding scale. and according to what that patient's blood glucose is before their meal is given to them, we will definitely cover that patient and determine how much insulin we will give that patient by the physician's order. Okay. We know our rapid insulin is our Novolog, our short-acting is our regular insulin, our intermittent insulin is our NPH or our Levemir, and our long-acting is what we call Glargine or Lantus. Okay. It's also important to know, what insulins we can mix together, and when we do mix insulins together, how do we go about mixing them in the correct way? All acute care settings and hospitals have some kind of protocol in which we should adhere to when our patients develop hypoglycemia. And what do we mean by hypoglycemia? Usually that is a blood sugar below 70. And then what we should do for that patient if he develops a very high blood glucose, usually over 400 or 450. There is an order of what we should do, and obviously the physician would be definitely notified. There are, as I said, factors that influence insulin absorption: the site, the timing, the type, the dose, and obviously our patient's physical activities. It's important to know how to mix insulins, and remember our exogenous insulins from outside sources are either from a porcine or a beef source, either from pig or cow. Another aspect of administering insulin is really talking about the equipment with our patients, what they need in order to safely administer insulin. Obviously, they should be self-monitoring themselves at least 4 times a day, just like we do when they're in the hospital. They should be sure that they have sufficient amount of strips on hand, that they are performing the procedure of self-testing properly so that they're getting an accurate blood sugar results. They should have the necessary and correct type of syringes, and be able to effectively determine where that level on that syringe with their calibrations is, so that they're safely and accurately administering the correct amount of insulin. It's important to know that we would never, ever, ever reuse syringes again, that it should be a sterile procedure, that they really assess the sites, especially if they've been a diabetic for a while and they're giving numerous amount of shots, maybe throughout a month's time, maybe 2 or 3 or 4 shots a day. You figure that times 30 days in a month, they could give as many as 70 to 120 shots a month. So it's important that they understand to properly assess the areas so that they're not injecting into scar tissue or some of the complications of insulin injections, because obviously it's going to affect considerably how that particular insulin is absorbed. Insulin injection should be given at a 90-degree angle, and it should be obviously sub-Q route. So these are things that we hope we can definitely explain to our patients, as well as see a return demonstration to be sure that they are giving their injections correctly and using aseptic technique. Make sure they're washing their hands before and drawing up the proper amount of insulin so that they understand how the calibrations on the insulin syringe work. Usually insulin is given 0.5 or 1 unit per kilogram of body weight, and the basal, meaning that insulin in between meals, is about 40 or 50% of the total dosage, okay, of the insulin that one person would receive if they now have to start on insulin therapy. And this is just a chart that shows the preparation brand name, onset peak, and duration, okay? And very important to at least know what category a particular insulin is in. Kind of will give you some ideas when we talk about the brand names of Humalog and Novolog. You can see from the chart with Lispro, Humalog, when our patients are to have this administered before their meals, it should be given right when trays come to prevent any chances of a patient developing hypoglycemia. And in about 30 minutes to an hour, that's when you would see a patient develop hypoglycemia. And it really does have a fairly short duration of about 3 to 4 hours. And your Aspart or your Novolog takes a little bit longer, 5 to 15 minutes, but still it's important that the trays are there for that patient. So if you give it and the patient hasn't eaten, you wouldn't want them to develop hypoglycemia. Your regular insulin is your Humalog or Novolin R, and that is again another type of prandial insulin that you may see ordered for your patient. It's more of the short acting, works in about 30 minutes, peak of 2 to 4 hours, and lasts about 6 hours. Now your NPH is the only intermediate action insulin, and doesn't start working until about 1 to 2 hours after it's administered. This might be a type of basal type of insulin, might be given first thing in the morning. It's going to be a while before it works, and peak is in about 8 to 12 hours, but you notice that it has a long duration, and those are obviously meant to keep those blood sugars at a steady keel, especially if our patients continue to eat the designated calories that they should be getting, along with any type of IV fluids, or even in compliance with their exercise regimen, okay? And then your long-acting are your Glargine or Lantus. You'll notice that with Glargine or Lantus, again, does not work until about 1 to 2 hours after the insulin is administered. There is absolutely no peak, can last up to 36 hours, and really, again, tries to keep that blood sugar kind of at an even, steady rate. The thing about Glargine that is absolutely important that every nurse know, that it can never be mixed with anything because of the pH and the molecular makeup of this particular type of insulin. It cannot be mixed with any type of insulin, and that's really, really important to know. There are also mixed insulins. Maybe you might have a Humalog mix of 75-25. Usually if those are ordered for your patients, usually you'll see that bottle of insulin that's actually in the patient's name. That would be only used for that particular type of insulin used for that particular and specific patient, okay? So just a little bit of a recap on the different types of insulin. And I think with most of you have been giving insulin, that it is probably not new information, but you're probably aware of really what these onset peaks and durations are of these insulins, because I'm sure with administering them in clinicals, your instructors are asking you all the time, tell me about your insulin, when you're going to see this work, how long, when's the peak, and how long is it going to be on board. Also, review the procedure on how to mix a clear to cloudy insulin, okay? Your book does talk about the correct procedure in which we as nurses would do that, because if we can mix our insulins, it's important that we do, because there's no sense in giving our patients 2 separate injections, okay, if we can give it all into one, all right? That's just a little overall and recap of our insulins, and then the next PowerPoint slide is just the various sites that we may administer insulin. You can see behind the back of the arm, lower back area, in the gluteus, and even in the anterior portion of the body, in the thigh area, and even in kind of on the back or the sides of the leg area. Probably our most common places are in the abdomen, as you can see on the left, and in the deltoid, okay? When we talk about injection site, it's most readily absorbed in the abdomen, then the upper arms, and then the thighs, and then the hips. The speed of absorption is obviously greatest in the abdomen, and the arms, and then the thigh, and then the hips, okay? It's recommended that we don't use the same site for longer than 2 to 3 weeks, and particularly if your patient exercises in a particular manner, you know, through a bicycle, through swimming, you would not use that limb because it will absorb that insulin much faster and cause your patient to develop what we call hypoglycemia. So that's something that you want to also keep in the back of your mind, okay? Just a few other pointers about insulin. Factors that influence insulin is obviously the injection site, affects speed, and I just went over that, so be sure you're aware of where the fastest site is: abdomen, then the deltoid, then the thigh, then the buttocks. Absorption rate is determined by insulin properties. The longer it takes for the insulin to be absorbed, the more unpredictable that insulin is, okay? And the larger amount of insulin that you give also makes it much more unpredictable about when that will actually, you know, be the onset, peak, and duration of that insulin. Remember, if you have areas of scar tissue, that is going to slow absorption time down. Think about timing when we talk about lag time, pre-meal and eating. And then other things about insulin are some insulins are stored in the refrigerator, but never should be at a temperature below 36 degrees or any area that is a temperature greater than 86 degrees. You should always avoid excessive shaking of the bottle. Whatever insulin a person is on, they should definitely have a spare bottle of each. And when you do have these pre-filled syringes such as Byetta, which we talked about earlier, they should all be stored in an upright fashion, okay? And again, just to kind of recap what I said, your basal type of insulins are your NPH, Lantus, and Levemir. And then your prandial type insulins are your regular and your Humalog or your Novolog, okay? And again, all type 1 diabetics will be on insulin, and obviously sometimes your type 2s. Remember, we always are concerned when our patients are administering their own insulin, especially the safety of the older person that can be affected by reduced vision, mobility, coordination problems, and also decreased memory. Remember, insulin is a type of drug in which we cannot give it orally because it's inactivated in the GI tract. And our goal here is to mimic normal release patterns from the pancreas, kind of administer those exogenous forms of insulin just in the way that our own pancreas secretes insulin, okay? And again, for some patients, they may need basal amounts of insulin as well as prandial to prevent that increase in blood glucose after meals, okay? So just kind of some extra information in regards to insulin, all right? I talked earlier about lag time, and I just want you to be aware that lag time is that interval between pre-meal injections and eating. as when they're going to eat. And that's what we know is lag time, and where insulin should be given within 10 minutes before a meal, or sometimes even sooner. It's important, too, that even though we say generally, when we talk about administering a sub-Q injection of insulin at a 90-degree angle without any aspiration, maybe in a thin person, we might want to pinch and provide that insulin more of a 45-degree angle to avoid giving that person an IM, because obviously that would be a faster delivery of that insulin. A lot of times people, over time will develop scar tissue, and some people kind of gravitate towards that area because with scarred tissue, it often becomes the favorite site because it doesn't hurt as much, but we're really not seeing great absorption from that. So we want to pretty much kind of assess that to make sure our patients are not giving their own injections in that kind of an area, okay? Right here we're talking about complications of insulin therapy, and lipotrophy is the loss of fat tissue in areas of repeated injections that actually results from an autoimmune reaction to impurities in the insulin. And lipohypertrophy is an increased swelling of fat that occurs at the site of repeated insulin injections. And these are kind of things that we want to kind of assess, especially if someone's been a diabetic for many, many, many years, okay? And also realize, too, that if you do have insulin in the refrigerator, it's kind of nice to leave it out a little bit before you're actually going to draw up that insulin, because cold insulin can cause some irritation at the site. So that's something that you may want to think about in regards to leaving it out and let it kind of warm up a little bit to room temperature, okay? Lantus should actually be stored in the refrigerator. And one thing to know that's very important, especially as later on we'll discuss some of the emergencies associated with hyperglycemia, is that regular insulin is the only type of insulin that we can administer IV, okay? And that's very important to know. All the other types of insulin can only be given sub-Q. And of course regular can be given sub-Q, but it can also be given IV, and that is the choice of insulin that we use, especially when our patients come in with these serious complications such as DKA and HHNS, okay? As I said before, some of these pre-filled pens can provide a little bit more accuracy and a greater accuracy for some of our patients who might have some visually impairments or also be cognitively impaired, especially when they're given in small doses, as long as a person receives adequate education about how to give that, okay? Even with not regular, but any kind of insulin that our patients are drawing up, it's really important that we teach them about looking at the insulin bottle. Should it be clear? Should it be cloudy? Is there any other foreign material in that? They really should inspect the insulin before each use. And obviously use needle only once, because if they tend to use a needle more than once for cost purposes, that needle can actually break off, okay? And again, always storing those pre-filled syringes in the upright position, because if they don't, those insulin particles have a tendency to actually clog the needle, okay? And when you're using those pre-filled, it's really important to actually roll that pre-filled syringe between the hands, okay? Again, our goal is to, prevent infection and complications over time, wiping off the area, making sure that the alcohol dries, and preventing any of these complications that I just discussed at the site of where and when these insulins are given. Sometimes, a person who just begins to start on insulin may have a little bit of redness or swelling or tenderness at the site, and sometimes that happens about 1 to 2 hours after that insulin has been given. It can occur during the beginning stages, like when a person is first prescribed insulin, but it can disappear after continuous use because now we're using more of those human insulins. Very rare for people to have like a systemic allergic reaction. But again, as I talked about, lipoatrophy and lipohypertrophy, those may definitely occur with your patients. And sometimes, even when our patients are on insulin, they can also develop a resistance because some people still remain overweight and are considered obese, and sometimes we can label that person as being insulin resistant, and that may be defined as if you need a daily requirement of 200 units or more of insulin a day, okay? So in that case, we may want to give a more concentrated insulin, and there is what we call a U500 insulin, okay, because we're having to give more and more, all right? So I hope that kind of brings a fair amount of recall and knowledge about insulin administration and things that we as nurses need to continue to do. And obviously teach our patients about, in keeping them safe, free from infection, and making sure that they have that insulin with them at all times, especially if they're covering themselves according to a sliding scale that we actually do while they're patients in the hospital, of course. So hopefully that all makes sense. Two things that we'll just kind of discuss briefly are the Dawn phenomenon and the Somogyi phenomenon, okay? And what the Dawn phenomenon is, it's an actual nighttime release of growth hormone that actually causes blood glucose elevations at about 5 or 6 o'clock in the morning. That's why we call it a dawn phenomenon, okay? Because it occurs, at the dawn hours, all right? It's a hyperglycemia in the early AM. We see it more in females and teens, and again caused by the growth hormone release. And remember, we talked about growth hormone being one of those counter-regulatory hormones, okay? So how do we avoid this big spike in blood glucose during the dawn hours? We would give more insulin for the overnight period. Give more of an intermediate insulin at about 10 o'clock the night before, because remember, think about what the duration is. It's about 6 to 12 hours. And then we would encourage that person to avoid a carbohydrate at bedtime, and maybe if they exercise, to exercise later in the day, okay? The Somogyi is just a little bit different. It's a morning hypoglycemia from the counter-regulatory response to nighttime hypoglycemia. And usually when this first change in blood sugar occurs is about 3 o'clock in the morning. So if you actually set an alarm for about 2 to 3 a.m. in the morning, we would test the blood sugar, and what we would see is a decrease in blood sugar. And so what you have is hyperglycemia followed by hyperglycemia because of those counter-regulatory responses involved. And because this blood sugar really drops quite significantly, many times a patient will really have vivid and crazy dreams at that time, and that could be another indication that the blood sugar has really dropped. And so this low blood sugar may happen while they're sleeping and be very apparent by about 2 or 3 in the morning. and because of the excessive insulin that was given the night before. So what you would do is definitely switch out that NPH insulin, give more of an HS snack to prevent that drop in blood glucose at 2 or 3 in the morning, okay? And then the reason it kind of spikes is the fact that those counter-regulatory hormones kind of kick in, all right? So that is the dawn and the Somogyi phenomenon. And I think this next slide shows the graph of exactly what happens. And you can see the red line is the dawn, where you have pretty much of a stable blood sugar throughout the night, and then it spikes up in the dawn hours. And then your Somogyi, you can see, is the purple one, and that's where all of a sudden about 3 o'clock in the morning, a little past 3, the blood sugar really starts to drop, and then you have a rebound because of the counter-regulatory hormones that are definitely activated. But the patients can get very, very symptomatic with the Somogyi because you can see that the blood sugar really goes significantly lower. Okay, can get down in the 50s or 60s. So that's those two phenomena or events that occur. All right, now let's just talk a little bit about alternate methods of insulin administration. We've talked about the individual insulin injections that someone may administer to themselves depending on their Accu-Chek or glucometer readings. But our patients may also have a continuous subcutaneous infusion or a implantable insulin pump, which does need someone who has a fair understanding or a fairly good understanding of the apparatus, as well as, you know, making sure that it's being filled with the correct amount of insulin, and that a person is aware when the particular device is not functioning properly, because then we can see people or our patients develop problems with their blood sugar, causing them to have hyperglycemic problems. Your continuous subcutaneous infusions really do allow a lot of flexibility in meal timing, because if the meal is skipped, the insulin will not be given. They use rapid-acting insulins in those particular devices, and it adjusts the amounts of the insulin received based on data from the blood glucose monitoring. Okay. Now, even though this sounds really good, there can come with these type of infusion sets problems. You can develop skin infections. There's just a very thin needle that's embedded in the subcutaneous tissue, and this needle needs to be changed every 2 to 3 days. So this makes a person that has this type of device more prone to hyperglycemia or ketoacidosis. They really do have to have adequate pump knowledge. They need extensive education. And if their blood glucose is consistently at 300 or over, they really need to check for ketones, okay? You know, that's what you have to make sure. Some of these pumps can be very, very sophisticated. I know they've really just really made them so much more technologically savvy, where they really provide a lot of information. Some of them can actually be transcribed back to a physician's office to kind of get an idea of the trend of someone's blood sugar. They also have a great memory that kind of has all a person's blood sugars stored on that. When a patient is having difficulty or really feels that they're maybe either getting hypo or hyperglycemic, there's ways in which we can determine, when that did happen. So maybe a person can look back and say, yeah, that's when, I didn't have too much food, or I had too much food, or maybe, they had some other event going on which caused their blood sugars to become a little bit erratic. So the pumps are really, really good, but some of them can be extremely expensive, can run as high as sometimes $2,000 and $3,000 for these pumps. Some of our insurances do cover the cost of these pumps, but just so you know, the insulin that is put into these pumps really is not very cheap. I think I checked or asked somebody that I knew was diabetic, and they said a bottle of insulin is about $125. So not very cost-effective medication, but obviously a medication that obviously a diabetic needs. You could pretty much say that insulin is their lifeline. Okay. We also have insulin pens. They're insulin loaded into a pen-like holder. It's a disposable needle is attached to the device for the insulin injections. It's delivered by dialing a dose or pushing a button for every 1 to 2 units of increments of insulin that's been ordered. And it's very convenient for patients who need to inject only one type of insulin at a time. If you're going to eat out, if you're traveling, if you have a little bit of impaired dexterity, if you have vision or cognitive dysfunctioning. Okay, so that's another method in which to dispense insulin. Okay. There are also needleless types of devices where the insulin is absorbed at a faster rate with a shorter duration of action. These are very, very expensive. They are replaced by an ultra-thin liquid stream of insulin that's forced through the skin under very, very high pressure. Okay, and so that might be also an alternative, but it also is very costly. Okay. And sometimes because the pressure needed to push that insulin through the skin may leave the skin with some slight bruising. All right. Going back to our insulin pumps, here's, let's see, this is an external insulin pump right here in the picture. As I said, it's a very, very tiny needle or catheter that's in the subcu tissue, usually in the abdomen. Usually to keep that intact, you would definitely secure it with tape. And it's important that the needle is changed every 3 days to avoid any type of infection. Usually it's administered at a basal rate of about 0.5 to 2 units per hour. And after a meal, a dose of insulin is calculated based on the amount of carbohydrates that are ingested, usually about 1 unit for every 15 grams of carbohydrates that a person eats. There are some disadvantages to this. Unexpected disruption in the flow of insulin can cause your patient to develop hyperglycemia, or even if the insulin runs out. Also, if the battery is depleted and it's not working effectively, it can increase the risk of DKA. But like I said, these devices are so sophisticated now that really it alerts to somebody when the battery is getting low, or probably when the insulin is getting low. It can be at times inconvenient to wear, but it can also be disconnected for showering, exercise, or any other type of activities that will, have the machine or pump get into the way. But again, it's important that you have adequate knowledge and be in communication with your endocrinologist, your dietitian, or your nurse educator, or your diabetic educator. Only use rapid-acting insulin, And you should also have the knowledge that you may have to give an injection if something would happen that your pump would not work effectively. So that's something to keep in mind. Okay. And going back, obviously diabetics travel, and it's very important that when traveling, always carry with you when you're flying, and make sure that you have enough of the medications, especially if you're going out of the country, and make sure that it's not kept too cool or too hot, because with too hot of insulin or too cold insulin will definitely affect the patency of the insulin, which could be a very, very bad thing and cause your patient to be very much at risk for developing those emergency type situations with increased blood glucose. Okay.